that we have. Okie dokie. Looks like almost all of us are here, so that will work. And I'll start us off with, let me share my screen. I hope everyone had a good Thanksgiving, by the way. I forgot to ask. I mean, a weird, like a COVID good Thanksgiving, okay? So, but hopefully you got to eat some turkey and hopefully take a break because that's really important. I went camping. I just want you to know that. I was very outdoorsy, so I'm proud of myself because I got jealous with everybody's self-care stuff, all your outdoorsiness. So I was like, ooh, I need to do something. However, I went camping in the desert and it's very cold at night. So I need to work on it. But otherwise, it was wonderful.
Where did you go camping at? Which desert?
Oh, Anza Borrego.
Nice.
It was wonderful. It was so beautiful because there's no light pollution. Well, very little. And it was a nearly full moon. So it was so nice. But I basically was inside the fire because it was so hot. It was so cold. Not so hot. And my dog hates camping. But I think he just doesn't like cold weather. I can't tell. But I'm pretty sure he hates me and camping. So just a little FYI, Chihuahuas do not like camping in the cold weather. Anybody else do anything out of the ordinary, out of COVID or no? Nothing? Get some good food? No? Aw.
I went skiing.
Huh?
I went skiing, which was fun on opening day up in Tahoe.
Oh, wow. Where?
Well, we were gonna go to Squaw, but there were like 17-mile-per-hour winds, so we ended up going to Alpine, so right behind Squaw Valley. Yeah, it was really fun.
So you seek out cold weather. Oh,
yeah.
So cool. Interesting. And brave, but I love it. I think skiing is so cool, but I prefer to watch from indoors. Anybody else? Anybody going to do anything with their break that they're excited about? Everybody's like, can we just do this? Okay. All right, so let me show you what I did. So if you go to the homepage, I went ahead and clicked through. So this is the peer feedback form. So what I did, and I hope this isn't confusing, I just published it on purpose. So I didn't want you to look at it too much, but please read through this on your own very quickly. It's just reminders. But what you're going to do is you're going to download this Word document. You're going to download it once today and once again next week. So just download it once today, and it's a Word document, so you'll download it and you'll put your red ID here. The presenters will not get this form. I will get it, and then I'm going to prepare a form for them. But this is a drop down. You can't see it because it's PDF, but this is a drop down. Well, the view is PDF. And you'll select whoever you're about to talk about, and then you'll answer these questions. So the green line is one person. So there's two people, two presentations or two presenters per form. Okay? And this is a professional courtesy. There's no grade. This is just the way that you're going to help each other. Okay? And I want you to notice one thing. There is no Likert scale here. There's no 1, 2, 3, 4, 5. And there's a reason for that. Does anybody know why? What do we say about Likert scales? That they're always skewed, right? So since we all know each other, we are already biased because we are biased to giving each other the benefit of the doubt, to liking each other, or at least not horribly disliking each other, right? So the odds of you giving somebody a 1, as in the worst, are very minimal. And so it's not useful information. And typically, this is the case for when you're judging anybody, like in evaluations and things like that. Whereas Likert scales work better for self-perception. That's why Likert scales are good for your judgment about you, but not necessarily good about evaluations of other. Like, you know, you can say, this movie, how did you like the movie? 1, 2, 3, 4, 5, right? How did you like the movie? But you're not qualified to say, was the movie filmed well? Well, you're not a filmographer, so you can't say, does that make sense? So that's not an appropriate question for a liker. So this is why everything you have is fill in the blank. And if you notice, the space is appropriate to how much feedback you might put, like 1 or 2 bullets per question.
Oh, Dr. Shafina?
Yeah.
I have a quick question regarding this this layout. Underneath it, since it's a survey, do you want us to submit it after we click that button, or do we upload it?
It's an ungraded survey, so it's not a real survey. So I'll finish that in just a second. Right now, I'm just looking at the content. That's a great question though. But right now, this has 4 sheets for a total of 8 people, right? So we have 8 people per day. And then you see here, oh, you can't see it here. Why not? Oh, I'm instructor view. This survey has 2 questions. So question 1 is you upload for day 1. Question 2 is you'll upload next week for day 2. Does that make sense?
Yes, thank you.
Okay, good. Because I was gonna do drop down are hard unless I did Qualtrics, and I didn't want to code a full like Qualtrics survey because that's a bit more labor intensive. So this was a nice little Word document. And just to give you an idea, this is what it looks like. Let's see. So if you see here, you'll drop down and all of your names are in here. So every single time you just go here and you pick whoever's presenting, you put their name. Okay? Does that make sense?
Wait, Dr. Shavina?
Yeah.
So does that mean you would want these 2 surveys, evaluations, or documents sent in next week when we're done with all the presentations? Because there's 2 questions.
No, that's why I said that there's only, if you notice, there's only room for 8 at a time. So it's day 1, you'll upload today because your presenters today need your feedback today.
Oh, okay.
Yeah, so you'll write as you know, as soon as they finish talking or as they're doing questions. So that's why, see, it's only half a page per person. Yeah,
but so does that mean that we can open this quiz up again to like turn in the second day?
Yeah, there's no due date. It's not a quiz. I know it says it's ungraded survey. I don't know why it says that. But yeah,
okay.
Download this. Look, see this little arrow here?
Yeah.
Download.
Okay, just making sure.
You're saying
you're saying it's ungraded, but it is required, right, for us to do?
I will not take points off, but it is a professional courtesy.
Oh, okay.
Peers would appreciate your feedback. So, I mean, I'm hoping that you'll do this because I do expect you to be here. And if you can't be here next week, like let's say you're at a conference, I do hope that you will watch the video and give feedback to your peers. And so, see, I downloaded it and now I'm ready to roll. And then what I can do is save it as day 1, or I can save it as a PDF, you know, whatever you want, and then upload it. Does that make sense? Does that work for everybody? Okay.
For those of us,
oh, sorry, Irene.
I was just going to say real quick, for those of us who are presenting today, we would just have one box that is correct.
Yes. You do not review yourself. No. Yeah. Great question. Almost forgot to say that. Yes. People presenting today, you would only fill out 7 or however many people, not you. And that's how I'll know you're presenting today, because your red ID will be you. Really good question. I always forget to tell people that. Did somebody else have a question?
Yeah, Professor Spino. So I just wanted to clarify. So we're going to fill out 3 of these forms, correct? Or 3.5, because there's only spot for 2 people each.
Sheets of paper. Yes. Because each one counts for 2 presenters. Yes.
Got it. Okay.
You're counting the sheet, right?
Yeah, sheets. Okay.
Yeah, just make sure you cover every person presenting. And you'll have the drop down, so you can't miss it. Okay.
My Microsoft Word is just out of date, but it's not giving me an option to drop down. And I also but I also have a really old version of Microsoft, so
Then you're gonna have to just type in their name. Just type first name and first letter of last name, because that's how I'm gonna search them. So I was gonna toggle and aggregate. But yeah, just type it in. You're not getting out of feedback, Missy. Okay. Any more questions, comments? All right, without further ado, let's get started. So I'm gonna stop sharing. And as a reminder, I don't care what order you go in. I'm going to start at the top, and then whoever is willing. And remember, I am cognizant. So be cognizant that this is the first group. It's a very brave group. So let's be kind to each other, but also let's give some helpful feedback. And also be cognizant of the fact that we're not evaluating how a person presents. This isn't, because none of us is a professional presenter, including myself, although it's basically like my bread and butter. But even though I still have room for improvement, we're evaluating what we know. And we are now experts in data, information, knowledge, and then to a certain extent, action. We're getting there, right? That comes with time and experience. So that's what you're focusing on. We're focusing on understanding the research question. We're focusing on, that's why the questions that you have are the way that they are. Does that make sense? So don't feel any pressure to evaluate anything other than what you see. But do provide what would bring more value. If you were in a conference, in a boardroom, what would bring more value to that presentation for you? Okay? Any other questions, comments, concerns? All right, so I have Dalen, Jimmy, Brandy, Kira, Luke, Cameron, Irene, and Jonathan on deck today. Who would like to go first? Whoever can clear and share and go. And I will start the clock.
I mean, if no one else wants to.
That's exactly what we want to hear.
I actually recorded my video, so that's still okay, right?
It is.
Okay. So I will share. Okay, and just let me know that everyone can hear
You
it.
will need to be prepared to answer questions in person, though. You know that.
Yes, yeah, I know that.
All right.
Okay, so just someone give me a, we hear that, that would be great. Once it starts.
So I did my research on hospital community partnership programs.
Thank you.
For segment data to information, so my research question was, what are the characteristics of hospitals that have implemented these partnership programs? And why is this important? So basically knowing this information is important for hospitals that either want to determine the common characteristics among hospitals that have implemented these programs, or to determine the end goal and to see if your hospital has a certain characteristics that are important for community partnership program implementation. So I found 2 peer-reviewed articles that were consistent with my research question and discussed the characteristics and relationships between hospitals and health promoting services. Before reviewing the literature, I hypothesized that smaller not-for-profit hospitals participating in a joint venture or health system are more likely to have hospital community partnership programs. In the literature review, there were several convergent and divergent themes. However, even though divergent themes exist, common variables that were highlighted between both articles include bed size, ownership, quality, community orientation, location, joint venture, alliance, health system, and network. So for the study design, I gathered data from the AHA dataset. The target population were hospitals, and I utilized the AHA dataset glossary, questionnaire, and services sections to identify any variables that are associated with these hospital partnerships and outreach initiatives. There were external threats to validity, which may include geographic location of the hospital and the hospital's previous history of partnership programs, as well as other demographic factors. On the other hand, internal threats may include data collection bias from the researcher, as well as any other testing or selection bias that may have been present when collecting the data displayed in the dataset. There are many different users of this information, and since my research question is broad, I decided to use this descriptive analysis for this research question. So here are my independent variables. I created a whole new data set focused on just general medical and surgical hospitals. And these were the independent variables identified from my literature review. And then for my dependent variables, I identified these 7, but really it was 21 variables since each variable was categorized in hospital, joint venture, and health system categories. And I recorded all these variables into my primary dependent variable called system partner, which means having a community partnership program provided by a hospital or provided by a hospital participating in a joint venture or health system. Information to knowledge. And so here is my table 0. As you can see, there are more hospitals that are not for profit in a metropolitan area and are accredited by the Joint Commission. In general, bed size varies, and most hospitals have less than 199 beds. In terms of total capital expenditure, the standard error is about 1.1 million, which is less than the mean of 15.8 million, and the max was about 1.9 billion, which definitely may have skewed the results. And then for dependent variables, so some key things to look at here is that in general, there are more no answers than yes. However, most hospitals did provide community health education and nutrition programs, which is down here and then up to the right over here. So here's my table 1. In general, there are less community partnership programs provided by hospitals that participated in a joint venture or health system compared to just standalone hospitals. And this was not consistent with my hypothesis. And then when looking at location, most of these programs were provided by hospitals that were located in metropolitan areas. And this may be because urban areas tend to be more concentrated and therefore metropolitan hospitals can reach more people quickly and effectively. Also for rural areas, the element of distance actually plays a role in how many people these hospitals with these programs can reach. So I think my next step may be to look at how rural hospitals can overcome these barriers while still implementing effective partnership programs within the community. So for total capital expenditures, basically most of these programs were provided by hospitals with low TCE. And this may infer 2 things. So first, lower TCE might mean that there are smaller hospitals and therefore smaller hospitals are likely to provide these programs, or hospitals with low TCE may have more money to spend on discretionary services like these programs. And this may be because they are either more efficient or they are actually larger hospitals and have more economies of scale. Overall, this wasn't a good measurement because I should have looked at % of revenue of TCE instead. So here's my histogram. So more community partnership programs are provided by both not-for-profit hospitals, just standalone hospitals, and those participating in a joint venture or health system. And this was consistent with my hypothesis. So this makes sense because not-for-profit hospitals must provide community benefit to obtain tax-exempt status. In this case, offering these partnership programs is one way to reinvest in the community. Findings. So did my findings agree with my hypothesis? So again, here's my hypothesis, and the answer is no, not really. The opposite is actually true. So based on my findings, hospitals not participating in a joint venture or health system were 60% more likely to provide community partnership programs, and hospitals participating in joint ventures and health systems were more likely to have greater bed size as well. So what are the characteristics of hospitals that have implemented these partnership programs? So really it would be a hospital not participating in a joint venture or health system. It would be identified as a community hospital located in a metropolitan area, have low total capital expenditure, and have a bed size of less than 199 beds and be accredited by the Joint Commission. However, these last 2 points aren't really as strong. So knowledge to action, and here are my strengths. So data collection was cost efficient thanks to Dr. Shafino for supplying the data set. Descriptive analysis is considered to be expansive compared to other quantitative methods, and it gives a broader picture of an event or phenomenon. So since my research question was broad and focused on identifying hospital characteristics, this was a useful method of analysis. The AHA dataset represents data collected by more than 6,200 US hospitals and more than 400 US healthcare systems. So having hospitals as my target population is good since there's a wide variety of hospital data and the US hospital data is relevant to our country. And the findings can be generalized to US general medical and surgical hospitals since I created a subset of this data for this population. Limitations, so since I will be using the AHA data set, or since I use the AHA data set, an unintended consequence may be only collecting data from hospitals in the US. Also, I didn't acknowledge any new models of care delivery, such as FQHCs and others that may have engaged in these partnerships. And this is 2014 data, which may not be generalizable to the year 2020. I also previously discussed the internal and external threats to validity. And I was the primary researcher, so there is always opportunity for biases to be present. And there were over 1,000 missing frequencies, which was also a limitation. And I feel like I could have definitely spent more time than just one semester analyzing this research. So I do think time constraints was a limitation as well. Lessons learned. So in terms of the literature review, I definitely wish I had more time to research more articles than just 2. It would have made my variables even more reliable. In terms of variables, I think the first go around, I may have chosen too many variables and I was a bit overwhelmed at the start, but it all worked out. And it would also be useful to look at both environmental and external factors next time, since the literature review described how median income, population age, and FPL played a role in providing these partnership programs. My findings were not completely consistent with the evidence that I found in my literature review, and that's okay. It just proves my first point in needing a bit more time to find more articles than just 2. Also, next, I think I need to look at the percent of revenue of total capital expenditures, and I also should look up how rural hospitals can overcome their barriers while still implementing effective partnership programs within the community. So in terms of action and decision making, so these findings can be used to observe the common characteristics of the hospitals that have implemented these programs, also to compare the similar and different characteristics of hospitals that have implemented these programs, as well as to evaluate which characteristics are essential or maybe more essential for providing a successful community partnership program, and to determine the end goal and to see if your hospital has the certain characteristics that are important for program implementation, as well as to initiate change in the target community and to use this information in the planning process of partnership program implementation and to determine any barriers involved. So that is the end of my presentation. Let me know if you have any questions.
Oh, you timed that right on.
Yeah, that's why I had to record it, because I realized I practiced so many times and I was like at 12 minutes, 13 minutes, 14 minutes, and I was like, I just have to record it so I don't risk it.
All right. Well done. Well done. Well, thank you for being our first Brave volunteer. So before I ask any questions, is there anybody that has a question or wants a clarification or anything like that?
Yeah, I'll ask a question. What was the most difficult part of your data set?
I think the most the most difficult part was definitely just importing the data into SAS because I had a difficult time doing that. But once I got the hang of coding, it honestly was a lot easier to figure some things out. But I think recoding everything into the main outcome variable was a bit difficult because there were a lot of different steps involved and also just a lot of different variables that I chose. But Dr. Shapino helped me with that, so that was nice. Tui, did you also have a question?
Yeah, thanks, Aaron. That was amazing, and I loved seeing your graph shown. I was like, yay, all the hard work paid off. I wanted to get some clarification on is it the total cost expenditures and how that affected your like how that affected like the rural regions again, because you were awesome with your pacing. I just missed that part because my internet stopped.
Yeah. So what I found was that there were more hospitals which were just standalone hospitals and hospitals participating in joint ventures and health systems that were located in metropolitan areas and had low total capital expenditures. So what I pretty much concluded for like location was that potentially in metropolitan areas, there may be more opportunities to like develop partnership programs, since there may be more like social services and other agencies or programs in metropolitan areas, and metropolitan areas are also more concentrated, so there's kind of more people to reach. But yeah, and so that was the barrier with rural hospitals, is that even though there still might be a lot of people that they need to reach, they might not have as many opportunities to establish partnerships because it's not as a concentrated area with social services. And then total capital expenditure. So this variable was kind of difficult for me a little bit, but in general, most of these hospitals had low total capital expenditures, which I was inferring that that might mean that these are smaller hospitals because they have low total capital expenditures that are like providing these programs. Or it just might mean that if they have total capital expenditures, maybe the hospital is more efficient, or even larger hospitals and have more total economies of scale. But in general, I think I needed to look at like percent of revenue of total capital expenditures instead as my next steps, because that would have been a more useful measure in my eyes, at least, I think so.
All right, that's the last question in the interest of time. So I will ask a quick question, but I think you did great with the questions, Tamarin. I think you're also ready for a multivariable regression model because that would also help elucidate that question. The one question I have for you is to tell us why you chose your outcome as a composite of hospital funded partnership programs versus joint venture or what was the other thing?
Health system.
Yeah, versus not any programs. So I'm curious why you did that.
Yeah, so based on the literature review, actually both articles mentioned that hospitals in either joint ventures, health systems, alliances, networks were more likely, or not more likely, but maybe had more of the ability to provide these programs. So since each of those variables were categorized into hospital, joint venture, and health system, I decided to use all of those and then compare it to just standalone hospitals to see if that information was true. And in my sense, it actually really wasn't, since there were more just standalone hospitals not participating in joint ventures or health systems that provided these programs.
Okay, very good. Thank you. Does that make sense as to why the hypothesis was not supported then? And it was a surprise to me as well. So, and I have a few more notes and just housekeeping stuff for your final. But that's it. All right, good job. I know you can't hear class, but there you go. Okay, who's next? Any volunteers? Pop it up. Come on, guys. We want to get the time going and still have time for a little bathroom break if we can. Anybody?
Professor Spifino?
Yes?
I'm not going today, but I had a quick question. You just mentioned giving her feedback for her final. What are you referring to there?
Her slides, they're due Friday.
Oh, I see. Okay.
Yeah, when you go next week, your slides will be due that Friday.
Oh, got it. Okay. Thanks.
Of course.
I'll go.
All right.
Can you guys see that?
Yes.
Awesome. All right, so I did my research project on hospital spending on medical equipment and how it affects hospital-associated infections. So my research question was, does higher spending on medical equipment lead to less hospital-associated infections? And here's my project overview. I'm going to go through the data information knowledge framework and discuss the background methods, results, discussion, and conclusion. And so as far as a little bit of background, on any given day, there's about 1 in 31 hospital patients has at least one healthcare associated infection. And there's an estimated 687,000 HAIs in the US acute care hospital system in 2015, and about 72,000 of those patients die during their hospitalization. And so these infections are very serious, and they lead to tens of thousands of deaths every year and cost the healthcare system billions. And so preventing the spread of disease actually hospital-associated infections actually begins with proper equipment management, and proper medical equipment is linked to higher quality of care. So the studies that I found suggested that medical equipment quality was associated with infections acquired in hospital settings. And a study that I found analyzed specifically hospital investment on property, equipment, and PPE, and they did find a significant relationship between higher investment and higher quality of care related to lower HAIs. So based off the literature, I hypothesized that higher hospital care spending on equipment would lead to less hospital-associated infections. So as for my methods, I gathered my data from the hospital utilization data from the CHHS open portal database and the Centers for Disease Control and Prevention. So the CHHS data set had a ton of data on specifically to California hospitals. And sorry, did I say CDC? I meant the CMS data set. And so the CMS data set, they had a ton of data on the hospital acquired infections at a hospital level. So the study design that is kind of unique because the CHS data set is a required utilization report that must be filed by the OSHPD. And the CMS data set was collected through the National Healthcare Safety Network. And so they provided, so that survey provided information on the infections that occurred in a hospital. One of the most challenging parts of the entire project was actually merging these two data sets together because there was no common numerical variables between either of the data sets. So I had to manually merge them by their name and address and filter for only California hospitals in the CMS data set. And then I further narrowed it down by only looking at the catheter-associated urinary tract infections, just so the data was a bit more manageable. And then I took the SIR, which is the standard infection ratio from the CMS data set, and merged them to the CHHS hospital utilization data. And so an SIR is a summary measure that measures the rate of hospital-related infections and takes into account differences in types of patients and hospital that the hospital treats. So it's basically a confidence interval. And so at the lower limit, if it's greater than 1, it means that there were more HAIs in the facility than were originally predicted, and they're actually classified as being worse than the national benchmark. And then SIRs on the upper limit are ones that are less than 1, and they're considered better than the national benchmark. And then if they include 1, then they are considered no different. And so after my data was merged, I then focused on variables that would answer my questions. So the data set included how much, if each hospital spent over 500K. And so that was my independent variable. And then my dependent variable was the SIR. And then the next step was just to find that relationship. And so here are my tables 0 and 1. So I focused on my independent and dependent variables. And then my covariates from the literature, I wanted to look at hospital bed size, which a lot of the hospitals, as you can see, 41% were less than 50 beds, but then there was a bigger majority that were greater than 50 beds. And then I also looked at their license type, so what type of ownership they had, what type of hospital they were, and the main service that they provided. So most of the hospitals were nonprofit, and a vast majority of them were general acute care hospitals. And then most of them were just general medical surgical facilities. And then as far as my table 1 crosstabs, I looked at these variables and a lot of them didn't have SIR. So you can see how some of the categories kind of shrink, especially the license category. They only had data on the general acute care hospital. So that made up 100% of that cross tabulation. And then I looked at the chi-square values. So the hospital bed size and the license type were significant. So they had p-values that were less than 0.001. And so I wanted to focus on hospital bed size. And so I decided to graph that on the next slide. So I used a bubble plot because I wanted to see the relationship between the hospital care spending on medical equipment and then the hospital associated infections. So I just want to remind you that the higher SIR is not good because it means there's a higher amount of HAI. Lower and the lower SIR is considered good because that means that there are less HAIs. So the graph is indicating that the red dots are hospitals that spent over 500K on their equipment, and the purple dots indicate the hospitals that did not spend over 500K, and the x-axis is highlighting hospital size by number of beds, and the y-axis is the SIR value. So I just want to use this line to point out the variance. Okay. So there is clearly more variance on hospitals that spend less on their medical equipment. So that's not good because that means that they're having more infections compared to hospitals that are spending more. And you can see that there's far less variation in SIRs for hospitals that spend more on their medical equipment. So it appears that if you spend more, there is better patient outcomes. But I also want to highlight that these hospitals also were bigger. So you can see that the larger dots mean that they have more beds, which could also be a contributing factor. But judging from this graph, I decided that there was a relationship between hospital spending on equipment and hospital-associated infections. So as for my discussion, there is less variation in SIR among the larger hospitals. So it's important to point out that these hospitals see more patients, so their SIR values are more controlled because infections in their hospital will not affect their SIR as much. So if there's more variation among hospitals that did not spend at least 500K on medical equipment, although this is because of the size, so it could just be a reason because if there's an infection in a smaller hospital, it's going to make their SIR increase way more than it would a larger hospital. So it could also be possible, I consider that larger hospitals also, they need more funding because they have more patients. So that could be why they're being categorized as having spent over 500K on their medical equipment. But it definitely is just a factor to consider. And so the hypothesis was confirmed as well in the study findings because there's a relationship between healthcare spending on equipment.
1 minute, sorry.
Okay, no worries. And so the strength of my research is that the CMS database I used was very, very thorough. They had so much information on every single hospital in California. So I think that really did help my project a ton. And I also think that the research question was interesting, direct, and it was very relevant to hospital quality insurance. And as far as limitations, my study did not control for hospital size, which was an important variable that affected the results. And there's a lack of substantial literature specific to hospital spending. There was a law on medical equipment, but there was way more limited research on spending. And so I learned through this that merging data is not easy, and I spent a lot of time doing that. So you can save a lot of time if you just find a data set that has both of the variables you're wanting to study. And then in conclusion, my study confirmed that there is a relationship between spending on medical equipment and hospital-associated infections. And that indicates higher spending is associated with lower rates of healthcare-associated infections. And although I do think that further research needs to be done, that would control for the variable hospital size, since it is definitely a factor that affected my results. And then there's my references.
Hey. Excellent. Wow, you guys are like blowing me away right now. Like, is this the same class I started the semester with? All right. Questions, comments, clarifications.
I have a question, Kira.
Yeah.
So I really liked your graph, and I liked how you broke down, like the good and the bad with that line. Like in your graph, when you created the bubble chart, were you able to kind of like format that in SAS?
Format it?
Yeah, like I don't know if that makes sense. Like, because with the X and the Y axes, it looks like you had things filled out, and like would that option have been possible to include like the positive and the negative values of it, if that makes sense?
I'm trying to understand the question. So I just kind of used the code that Dr. Shafino gave us, and I just put in my variables, and it just kind of nicely formatted it for me. Are you wanting like the negative SIR values, or
just like the good or the bad associations of it? I just thought it was like really cool that you did it manually, but I wonder if the program could have taken on, like the SAS program could have taken on those into the graph, if that makes sense.
I'm not sure. Dr. Shafino suggested flipping the numbers and having 4 on the bottom, 1 on the, or 0 on the top, but I could not figure out how to do it, even through Google.
No, oh gosh, I'm glad you didn't, because that's not what I meant. So that's
Okay.
good. I meant to make sure we knew which direction was which.
Oh, okay.
And
okay.
you did exactly what I was hoping you would do. So because Kira made sure that we all understood what was a better outcome, good and bad. So that's the goal. When we do a viz, it doesn't always have to be perfect. It has to be helpful. And so when it's something that's explicit, you don't have to understand what SIR is. I already forgot what it stands for. But we do need to know, and she made very sure we did, is that less than 1 is good, more than 1 is bad.
Yeah.
And that was very clear to us.
It was.
I did not give you guys the code to label it, so she had to manually do that, and she
Gotcha.
did.
Yeah, great work.
It worked. Yes. It would be a little more challenging. I actually am not sure how we would do that, because that's a horizontal kind of grid label. And so we could do it. SAS will do it for you. You just have to do a little more coding.
I see.
For the advanced SAS class. You guys are good. More questions, clarifications? Anybody?
Dr. Shafino, I just have a general question really fast. I'm finding it super hard to pay like rapt attention and also fill out the form. Are we expected to do more than just like 1 bullet per area?
No, whatever is helpful. We are recording, so you can go back, but no, it's really what stands out for you. If it's really hard, don't stress too much about it. It's really more about giving feedback to your colleague.
Okay, thanks.
And you can also fill it out after. It doesn't have to be in the moment, if that will make it more helpful. It is a lot easier when you have the form in front of you on a piece of paper. So it's even been hard for me. I've just been writing stuff down by hand, and I'm going to transfer it to my electronic form that I made for myself. I have a different one because it's too hard. So I feel you. I tried to make it so that we could all be electronic. Okay, so I have a question for you, Kira. I have a couple. I really like this because there is definitely a lack of research on the economic impact on health outcomes. That's a really big area that is only recently, economists are really, not recently, but it's definitely been something that we care about cost, but we've always looked at it as just like, how much does this cost? But not, does the cost matter to the outcome, right? And so my question was, what proportion of the hospital's total expenditures, it would be cool in the future if we could know, I don't know if this was available to you, is what are they spending their money on besides this, you know? I don't know if that was something that you had possible. And then the other question I had was, if that number, you know, if there were smaller increments, because you talked about this hospital size, how much is a lot of money to a small hospital versus a big hospital? Do you think that mattered?
I definitely do. Like if you're a small hospital and you're spending over 500K, I think that's definitely significant and that would really affect the results. But the CHHS report that I had, or the data set, I mean, it didn't really break down like every single expenditure. I think they were looking more for like larger scale expenditures that they had. So they asked about like the 500K if they spent over that. But they like it was an option if they even put like what exactly they spent that on, and a lot of it was left blank. So
so it was like a significant expenditure.
Yeah.
Interesting. Okay. And then the SIR we were looking at specifically was for the CALT, right? The UTI, hospital-acquired urinary tract infections?
Yes.
So the other SIRs could be different?
Yes.
What other SIR, what other hospital-acquired infection might you be interested in?
I don't know. They had so many. Maybe MRSA or... Yeah, they had some gnarly ones, but I thought the catheter one was the most class friendly. So I just picked that one and it was pretty standard. I feel like that's a very common one, but MRSA would definitely be interesting as well.
It would be. It is much more rare. And so the literature would also probably tell you my personal favorite, C. diff. So that's diarrhea, y'all. But it's also although it's much less common now because everybody's washing their hands like crazy. All right, very good, Kira. Thank you so much. Excellent work. And then I will also give you more written feedback down the road, but very good. And it was a lot of work. I know you put a lot of work into that data entry. Okay, next person, who's up?
I'll go next.
All right, Dalen's up. Okay. Hang on, let me get my timer here. I'm slacking. All right, ready when you are.
Okay, so I did my research on disease outbreaks and infant outcomes. And so my research question was, how has experiencing a disease outbreak affected the quality of care for pregnant women as measured through infant outcomes? And you'll kind of see through as I go through my methods that my research question is really broad, but my data is a little more narrow, and I'll explain why a little later. So when I first started doing this, I looked at the literature, and a lot of the literature available on disease outbreaks and pregnant women have been related to COVID-19 because that's one of the most widely researched disease outbreaks of our time. So from these 4 articles, I found a lot of, so what they had in common was that they all talked about COVID-19 and pregnant women and their exposure status. So all of these women were either exposed or non-exposed to COVID-19. And what they differed in was their how they measured their outcomes. So some they measured the women maternal outcomes, some measured different aspects of infant outcomes. For the majority, they all had preterm labor as a common infant outcome. And they also, there was one article that looked at the monitoring of pregnancies due to artificial insemination, which was really interesting because usually when you do research on maternal outcomes, you don't look at that type of population in pregnancy. So the COVID-19 has really opened up a wide array of paths for new information on pregnant women and how disease outbreaks have affected them. So going off of this, I kind of narrowed down my focus on COVID-19. So for the background of my research, it turned into focusing on COVID-19 and seeing how pregnant women historically have not been thought to be as susceptible to COVID-19. So they haven't been a population that you necessarily consider vulnerable or as vulnerable as older populations. However, there is evidence from similar respiratory illnesses that suggests that they are at risk for maternal and infant outcomes. So that is something that should be looked at closer. And because of the pandemic, many women have not been able to go to their in-person prenatal visits, either due to hospital policy or fear of exposure. So that is something that has disrupted the quality of care. So because of these factors, I wanted to look at the data behind it and see how that has affected infant outcomes. And so for my methods, I did a PubMed search, and that's how I found these articles. And I used the mesh and clinical terms. And you can see the number of results according to my search words and phrases. And in my study, I included articles from any country, and I kept it broad to include any disease outbreak. But again, the majority of data available in the US is for COVID-19. So that's kind of why I focused on that. And I focused on all infant outcomes just because they were kind of spread out, and I wanted to see how different things impacted, but you'll see that I focus on one or some. And then I chose my data set based on the 2019 CDC vitality statistics, which is all birth certificate data for the US for the year of 2019. And I chose that because that's when COVID started, was in 2019. So these are my variables. I included my process map to show you how the birth certificate kind of shows these questions. So for the independent variables, I chose APGAR scores at 5 and 10 minutes, just because those are measures of health, and they basically say how close a baby is to infant death. So that's how they measure it. So the score you get is how close you are. The higher the score, the less close you are to infant death, so the healthier a baby is. So at 5 minutes, they test you, and if your score is less than 6, they test you again to make sure that it wasn't due to other things, and that it was actually due to the baby's health. And I chose covariates of date of birth, and that's shown on the birth certificate, mother's race, risk factors, and that's further delved into gestational diabetes, hypertension, and hypertension eclampsia. And the main factor that I wanted to look at was birth weight as an infant outcome. And so I recoded all my variables because I wanted to exclude unknown factors. And I also didn't want to include women younger than 20. The data set I used already coded, the way they coded it made it so that I couldn't include like 18 or older. I had to include 20 or older. I didn't want to include teens because they have their own, special like factors that could contribute. So I didn't want to include that population. And I also created categories of birth weight to make it easier. So very low birth weight, and birth weight. And I'll show you what the grams and stuff in the next slide. So I had a really large data set. So when I ran proc contents, I had over 3 million observations, which I will talk about later. But then I ran a proc frequency to get my table 0, and I did a chi-square analysis to get my table 1. So for my table 0, you'll see that very low birth weight was defined as 227 to 1,499 grams. And then you can see on the left here, like the different gram weights. But a majority of the babies born in 2019 were of normal birth weight. And a majority of them also had a score of 9 to 10 at the initial APGAR score, so they didn't have to get tested again. And when they did get tested again, a majority of them did have a decent score initially. And then most mothers were of age 35 to 39. Most women did not have comorbidities, and most women were either non-Hispanic white or Hispanic for the year of 2019. So just some little birth statistics. And when I ran my chi-square analysis, I found that all of these factors were statistically significant in terms of birth weight. So the 5-minute APGAR score, 10-minute, mother's age, mother's race, diabetes, hypertension, and eclampsia all had a factor in a baby's birth weight.
Wow.
So for my histogram, I had to do it on PowerPoint, and I'll explain a little later in my limitations is because my data set was too large, but you'll see that for the 5-minute APGAR score, it was the higher the APGAR score, the more normal the birth weight. So lower APGAR scores are associated with lower birth weight. And that was also true for the 10-minute APGAR score. And so for my analysis, to answer my research question, the lower APGAR scores were associated with lower birth weight. And there was also various factors that we saw, such as mother's age, race, comorbidities. But I wasn't able to answer my research question because there wasn't enough data on the exposure. So I didn't have any information available as to whether or not COVID exposure or any disease outbreak exposure really, how they impacted these factors. But some strengths to my research was that I found some insight on how pandemics can affect vulnerable populations because the pandemic has been so widespread. There is more research in a lot of areas that weren't previously researched before when it comes to pregnant women. And this literature and this data is really helpful to formulate clinical strategies, especially because.
Sorry, you have a little less than 1 minute.
Okay. And I had a really large data set, which is nice because I got a lot of information and data on birth outcomes, but some limitations were that because I was pregnant and I did give birth during this pandemic, there might be some underlying bias I have when including certain outcomes. My data set size was very large, so it was very hard to, first of all, it was very hard to open in SAS, and then it was hard to do the histograms in SAS because it was so large. My data availability, generalizability, it was hard to generalize because not all the literature is the same and they all look at different aspects, and I wasn't able to really answer my research question. But some conclusions, there was insight on how disease outbreaks affect vulnerable populations. I learned that my results may not be generalizable, and for the future, I'm going to compare this next year's data to my data to see how COVID-19 really did affect these birth outcomes. Any questions?
Oh, is that yours? Is that your little?
I had to put him in here because I had him during COVID, so I thought that was.
Well, he helped you.
Yeah.
Oh, he's so cute. Well done. Thank you. All right. Questions? Questions, comments, clarifying?
I don't know if this is too personal, but you mentioned that many pregnant women weren't able to go to in-person prenatal care. Did you feel like safe with the different like protocols?
I was pretty scared, but I was more upset at the fact that I wasn't able to go in more because it was my first baby and I wanted to make sure everything was okay. And he was really big for me. So sometimes he wouldn't move. And it like they're supposed to move, you're supposed to do kick counts like every so often. So I was frustrated that I wasn't able to be seen more because I did have more concerns. But when I did go, I was really cautious. I brought like Lysol wipes. I didn't sit down. I was very scared. But yeah.
Can you clarify the knowledge section again? So because of disease outbreaks, kind of like what I understand is that that is basically going to affect like quality of care and like infant outcomes and things like that.
Which are you talking about, a specific slide or just the concept?
No, I think just the overall concept.
So from what I gathered, the disease outbreak experience, so whether or not you have COVID-19 or if you're living in an age of COVID-19, you would look at different, like the stress level and like the health of that all affects the health of a baby. So then I looked at birth weight as an outcome because the way you take care of yourself and the way the health of the baby, that's a big factor in that. Am I answering your question?
Yeah, awesome. Yeah, I missed the stress factor part, which definitely makes a lot more sense now, how stress would definitely impact like birth weight and things like that. So thank you for clarifying.
Yeah, I didn't go into that too much. It was kind of in my, it was one of the literature that they looked at the stress of women going through artificial insemination. And it was on one of my slides, like 77% of women did not feel like they had increased stress because of COVID for that population sample. So they looked at stress. So that's why I said like there was different outcomes that they looked at. So it's hard to generalize the actual results, but that particular literature did look at stress as a factor.
So, okay,
Really
about all we have time for. I'm going to jump in really quickly and then we'll move to the next person. Thank you very much. Great question, Tamara. And actually, to piggyback off that, I am also curious about, because I like what you're setting up, because you actually are setting up the baseline comparison for when you get that COVID data as another covariate, in my opinion. And it's, you know, it's a great study that I think you should do, by the way. But what I would have, or maybe I just wasn't clear on is,
sorry.
Someone's dog does not like me or my voice. What I wasn't clear on was, let me see here. So one thing I think that might be better to include in the future, not necessarily for Friday, by the way, but is things like what else could you compare for other covariates like asthma or other respiratory illnesses? And then the other thing, and I think, again, sorry, to build off what Tamron said, I lost my train of thought for a second, is the added burden of COVID on an already burdened population, because you did describe the risk of comorbidities and African-American populations, is that right? So I think that, and you did describe that the population that, and if you go back to your slide, I can't remember if I saw it, but what race ethnicities, if there was a difference in who experienced lower birth weight, who was more likely to experience low birth weight?
Yeah, it was in my, I didn't really explain it, but it was in one of my slides with the literature that African American women do.
And what about in your findings? Was there a greater group who experienced low birth weight? Pop up your table 1, just real quick.
Table 1. It said that
So just for a general comment, everybody seems to be doing this, even though I told you guys several times, you have to do row percent, and I'm gonna show you why right now. For table 1, for the second table, the comparison,
Yeah, that
has
non-Hispanic
to be
white
row percent, and I'm gonna show you why.
women from this
So
state.
when it's the frequency table, we do column percent, but when it's the comparison, it's row. Because you want to compare low birth weight, not low birth weight by different races, right? But we can't see that because she gave us birth weight. So we're going to look at the counts and see, eyeball it. But she's going to fix that for me for Friday. Thank you. Where's that table? Are you pulling it up?
Sorry, I didn't know you wanted me to share my screen again.
Okay. Yeah, don't unshare your screen until you're done with questions so we can
Okay.
let's look at this, and it looks like we have, it's kind of hard. So see how we can't really tell by these percentages? Because what we're doing is we want to look at the row percent. So by being able to compare across, then we would see that the proportion of white women should be similar across all the, you know what I mean? So who bears the greatest burden by race? So you're comparing the race variation. That's why you would do the row percent, not column percent. Is this row percent or column percent?
Column, I think.
This looks like column percent.
Yeah.
Although, no, this looks like total percent of the whole thing, which is a little harder. Okay, yeah, you want row percent. So, because it makes it a little hard to see, right? Because right now we'd look at non-Hispanic Black, 16,110 divided by what? 3 points, well, actually total non-Hispanic Black women. Because this is 16,110 divided by 3,757,582. But we need it to be 16,110 divided by 16,110 plus 61,440 plus 470,480. That's what percent we need. Make sense? But that's in your SAS output. It comes out for you. So it goes, and you just pull it out. So you just read it, okay? But so the question is though, you know, what will make, what I think the strength of this is that you have the baseline of what is the current burden of racially and ethnic minority women. And by the way, if you look at the age too, I thought that was kind of impressive because it's all over the place. Babies are being born all over the place on ages, which is also surprising to me as a older woman. Not older, less younger, but that was also very impressive. So I would definitely look at that too. But anyway, so do you guys see the incremental, the burden of the incremental burden on the racial and ethnic group, on the age group, much like also with Kira's data, you know, like how much does every extra $50,000, what does that do for infections? You know, and so things like that, I think can make a big difference in how we visualize. For a clinician though, they'll care about the APGAR score. So it just depends on your audience, but that's something. So make note of this. It'll be in your, but I'll write it. I'll send it to you as well. But does that kind of make sense, Dalen?
Yeah.
It's a lot. But yeah, you want to know if there's already an existing burden, how much more of a burden is COVID putting on these people that are already at a disadvantage? Okay, next person. Oh man, we're got the hustle. So I know you guys have class soon. Who's next?
It might just be me at this point.
Luke?
I think maybe possibly.
Come on in. Well, you spoke, so you're up. You made eye contact.
Alrighty. Now
All
we done
right. Hang on, let me set my timer.
Okay.
All right.
Set
It's
a
not
timer.
going to make a sound when you have a 1 minute warning because I keep forgetting. So we'll now make that sound and reset it. Okay, ready when you are. Oh, well,
Right.
share your screen first.
Oh, that'd be a good idea.
Yeah, then I won't start the clock.
Look good? You see it?
Yep.
Okay, cool beans. And I'm setting my timer too. Alrighty. So for my project, I was looking at the difference in Medicaid patient populations seen by health centers in Medicaid expansion states compared to non-expansion states. This lovely image we have here on this title page shows you all the states that have expanded their Medicaid programs so far under the Affordable Care Act, and then the states which haven't in orange, and then the ones that are in the process of expanding Medicaid. So just kind of a visual intro to the subject. And there we go. There's the next slide. Okay, so for my research question, in 2019, what was the difference in the percent of patients seen at health centers who had Medicaid in states which had expanded Medicaid compared to states which had not expanded Medicaid? That's a lot of words. Basically, I'm asking, what's the difference in the number of people who had Medicaid in states that expanded versus states that didn't? Why this research question? So it's kind of obvious. You know, if a state expanded their Medicaid program, you would think more people would have Medicaid. I didn't want to go too far out of my comfort zone and try to answer a research question using a bunch of data that I don't understand, I'm not familiar with, given that I'm learning SAS for the first time. So I was a little conservative in what I asked. But also, this is a really important question. It has implications for my own work at Father Joe's, for FQHCs everywhere, and for the larger society. The Supreme Court right now is hearing arguments in California versus Texas, where Texas and friends want to invalidate the ACA, which would mean no more Medicaid expansion, which would mean, by my most recent guess, about 50% of our patients that we see here at Father Joe's would lose their insurance. Big implications. As an FQHC, Medi-Cal is our bread and butter. It's how we stay open. It's how we do what we do. Also, as I was doing literature review earlier this semester, I saw that a number of studies have been done looking at the effects of the ACA on Medicaid enrollment, but nobody had taken quite the approach that I took here using FQHC data, using the Uniform Data System, UDS. So in doing my literature review, I found 4 relevant papers. The first 3 that you see there, the Hahn, Hatch, and Huget, I think is how you pronounce that, they all looked at, they did quantitative studies looking at actual health center data where, so the Hatch paper, they looked at changes in payer mixes at health centers in Oregon during the Oregon Medicaid experiment. The Hahn and Huget papers looked at the effects of Medicaid expansion itself under the ACA, while the Salinger paper was more of a policy paper. Each of the 3 quantitative studies looked at like EMR data. They didn't look at big public data sets, which is what I decided to do. As far as I could tell, nobody had done quite this kind of analysis using UDS data. So what is UDS data? UDS stands for Uniform Data System. Every single FQHC and FQHC lookalike in the country is required to submit a UDS report. It's very extensive, takes about a month and a half, and I'm getting ready to start doing it in a couple weeks on January 1st. Very detailed. And if you don't submit that report, then you risk losing your HRSA grant, which for us at Father Joe's is a 7-figure grant. Gets much bigger for bigger health centers. So take Borrego, for example, biggest FQHC in the country. Theirs is probably in the many tens of millions of dollars. For my study design, so I cleaned up the data set, indicated which states had expanded their Medicaid programs by the beginning of 2019, which is the measurement year for most recent UDS data set. I excluded territories and outlying minor islands. So we're just looking at states because Medicaid expansion is a state thing. And then I went ahead and looked at the average percentage of adult patients who had Medicaid in the expansion states versus non-expansion states. Now, I was kind of disappointed when I realized all you need to do in order to do that kind of analysis is a t-test, hence our Tea Party. But we do need to include covariates, and that meant it was time for an ANCOVA, which took me forever to figure out how to do in SAS. That's what I was doing over Thanksgiving. But to start, here is table 0, which hopefully looks a lot better than the first time around, where you can see that I looked at 1,352 health centers. That's almost all health centers. There's just a handful in places like Puerto Rico and the Marianas. There's, let's see, the vast majority, not the vast, but the majority of patients seen at health centers are adults. And out of the almost 30 million individuals, the vast majority are below 200 and even below 100% of the federal poverty level. Also, Medicaid is the chief payer for most patients. Table 2, now with a row summary column, which I may or may not have just added like 5 minutes ago. Highlights from here, I have to refresh my brain. I draw your attention to this line, or this row right here, where comparing the expansion states to the non-expansion states, what percentage of patients had Medicaid as their primary payer? Oh, I just realized. So Dr. Shafino, in my rush to add this earlier, given your feedback in the last
I wasn't going to say anything. You better hurry up. You're running out of time. You're about to hit a minute. You better hustle.
Okay.
Wait,
well, then, all right, I'll go ahead and jump ahead. Here's the table 2. Lots of itty bitty p-values, which means significance. I also included the eta squared values for my main independent variable as well as the covariates. This shows the effect size for each of these. And then here's a figure, which looks like somebody took a red and a blue paintball gun and shot a wall a bunch of times. However, so what we're looking at here on the y-axis is for each health center, what percentage of patients had Medicaid? Okay. On the x-axis, what percentage of patients were adults? You'd expect, since Medicaid expansion primarily affects adults, in non-expansion states, as the number of adults increases, the rate of Medicaid coverage would decrease. And that's exactly what we see here. I also couldn't put the person's correlation coefficient in the graph, so I just put it down here for you. Then quick little discussion. Strengths, UDS data includes all health centers. Also 2019 is pretty recent. Limitations, if somebody is seen at multiple health centers in the same year, then they will be counted multiple times in the UDS data. If I go to family health centers, neighborhood health care, Father Joe's, San Diego Family Care, I will be counted 4 times. Also, people who have insurance tend to receive healthcare services more often. So people with insurance might be overcounted. Implications are that in the Medicaid expansion states, lots more people have, okay. Oh, this is the 1 minute mark. Okay. Yeah, so in expansion states, lots more people are covered by Medicaid and lots fewer adults are uninsured. So that implies that if Medicaid expansion goes away because the ACA is ruled unconstitutional, lots of people will lose their insurance. And then I also went ahead and threw in this little word cloud, Dr. Shafino, just for you. I Googled buzzword word cloud. So I couldn't think of anything else to put on this slide. So, any questions? Harold wants to know.
I do not stop sharing and go back to table one. And then everybody, questions, clarifications, and then go ahead.
Sorry, Luke, can you clarify again on that visual that you shared, like with the what you call like the paintball splatters?
Yeah.
Yeah, I just need you to of the patients. Can you explain that again to me?
Sure. So on the y-axis, we have what percentage of patients seen at the health center had Medicaid. And then on the x-axis, what percentage were adults, where each dot is a health center. It's one of those 1,350 something health centers. The red ones are health centers in expansion states, and then blue are health centers in non-expansion states. So the main population that's affected by Medicaid expansion is that Medicaid is extended to adults who are below 138% of the federal poverty level. In non-expansion states, you'd expect a lot of those adults to not be eligible for Medicaid. And that's why, kind of like I mentioned earlier, you would expect that as the number of adults decreases in the expansion states, the rate of Medicaid coverage would also decrease. So in the UDS data, for each health center, like they just give you the percentage of, what percent of all patients were adults, what percent of all patients had Medicaid. And then in one row, they get, or one column, one variable, they give you the total number of patients. So you can't really parse out and say, of the adults, how many had Medicaid? You could, actually, HRSA doesn't even have that level of detail because we don't submit it to them in a way that they could even do that. So it's a little tricky to really like tackle like the adult population specifically, but this is kind of a workaround, kind of a roundabout way of looking at that relationship.
Nice, good job capturing.
I see.
Thank you.
That helps a lot. That's a good question, Tweet. Good job.
Yeah. It took me a little while to come up with a visual that was like actually kind of
well, and it
meaningful.
It's good. I'm sorry to jump in because I know other people have questions, but I think also starting with what ceteris paribus is, so baseline or what we know it, is the blue line, right? Because that's what life was before expansion, which is more adults, less Medicaid coverage at the FQHC because adults weren't covered, right? They were covered by something else or nothing.
Or nothing, yeah.
Whereas with expansion, the variance is all over the place as expected. But I'm surprised because if you look at the tipping point, it's 0.6 is where everybody kind of, that's sort of where I'm curious about the expansion rules. And that kind of leads into my question because over half of the population is adults. So it doesn't, like it has a curious cluster there. It's not necessarily, you wouldn't have expected that. You would have expected something like this, at least a shift in the line, right? Which we do see a shift in the line, but that's not a real line because it's all over the place. Where blues are a little bit more linear looking, right? So everybody kind of, and so my question for you is that, like, do you have any ideas on that? That's your knowledge piece, right? That's not data or information because you don't have it, but you have knowledge.
Right.
From all your experiences, the literature, the frameworks, and now this, why do you think it looks like that?
Like why are both axes kind of clustered around the 60% mark?
No, so specifically because the blue one isn't. The blue one is more distributed.
Oh yeah.
The whole regression line, whereas the red one is clustered there, which makes me think, I have an idea, but I'm curious what you think. So
I don't totally 100% get the question, but I'll take a stab at it.
Okay.
So the adult population that we're looking at here is adults 18 to 64. So one of the populations that's not included in that is adults 65 and older, most of whom are going to have Medicare, regardless of whether or not they're in an expansion state. There's some exceptions, maybe in like border states, you might see slightly more older folks without Medicare. So I think seeing around 60% of your patients being, in that 18 to 64 age range is kind of a sweet spot for your regular old community health center. There'd be exceptions like us, where we see almost no children. Just because of the patient population that we serve. So let's see, percent adults, we would be somewhere up in this area, Father Jones, because the vast majority of our patients have Medi-Cal. Most of them are in this age range.
And they're adults.
Yeah.
Okay.
But you might have a health center that specifically just sees pediatric patients. There's an FQHC up in the LA area that sees almost entirely homeless pediatric patients. Whenever I'm trying to compare us to other health centers, they always throw my numbers off.
Well, that's something that I don't see in your limitations. So that should definitely be in there, because that's actually one of my questions is like, is there a way to tag the health center as a specialty type, not necessarily specialty, but like, like their base. Anybody else have a comment on that or thought? Okay, so we'll move on. But the other question I was thinking too, Wesley, was if there's a lot of new FQHCs that are catering specifically to the demand. So like, how old are the FQHCs? How long have they been around?
Oh.
So that might be something worth thinking about in the future.
Yeah, that is a good question.
Yeah.
Yeah, that data is out there. It exists. I couldn't tell you off the top of my head where to get it.
It's all out there. It's just about how we figure it out. All right.
Yeah.
Thank you for this. We'll have comments for this. And then I think this figure is good. It definitely needed a little more context, which you did very well. So that's very helpful, because I think this is an important table. And it does look
I'm just gonna.
I'll do, when you have a big sample, like Dalen's was humongous. And there is a code for that, Dalen, but it was advanced. So I was like, I'll teach it to you because you earned it, but I didn't want you to stress about it. Okay, who's up? Is that everybody?
I can go.
Oh, okay. Was that you that spoke?
Yes.
Cool. Let's do this.
Okay, so I also recorded mine, and I tried to get it. Let's see here. Everyone see that?
I can.
You can? Okay, perfect. All right, so I'm gonna start my timer as well, even though I recorded it.
I can't hear anything. Hello?
Oh. Let's see here. Let me try sharing again.
Make sure to press that volume button.
Okay.
Is it a video?
Yes.
Do you want to try to send it to me and I can try to play it, or what do you think? I don't know if that helps at all. I hate when that does it. I'm so sorry.
I know. Okay, let me try that. If someone wants to go right now, and then I can try figuring it out.
Okay, let's see. I've got Jonathan. Are you ready? Jonathan,
Yeah, I'm ready. I think so.
do you mind? Are you?
Yeah.
Is that okay, Irene? I'm gonna let Jonathan go. Okay. Why don't you jump in and give Irene a little time to troubleshoot?
Okay, sorry. Just giving time.
No worries. Oh, there we go.
Okay.
Right. Excellent. I can see it.
Okay. Yeah. So I'm gonna start now. So hi
Okay.
everyone. My name is Jonathan Aldana Mendoza, and today I'll be talking about the project I worked on, which is the analysis of burnout from a survey of registered nurses. Right. So to switch. Yeah. No. Okay. So what I want to begin by first defining burnout, what it is. So according to the World Health Organization, burnout is a chronic workplace stress that is not being managed. And what that results in are feelings of energy depletion, increased mental distance from one's job, and reduced professional efficacy, right? And the last component or variable that's important, especially for us as public health researchers, is how reduced efficacy in their job performance could result in reduction in delivery of care, and then also high levels of stress or continued high levels of stress, how that might result in lower quality of care, right? So according to one research group, a research study, sorry, physicians whose surveys revealed that they were experiencing burnout were 2.2 times more likely to report a perceived medical error. So those types of quality of care could be especially significant for like health organizations, right? So that's what kind of drove my research question, which is, do mental health intervention or strategies and programs help healthcare workers, specifically nurses, deal with burnout? And the focus of nurses was because I wanted the only database that I could find that kind of delved into this research question, which is the National Sample Survey of Registered Nurses, right? And what this survey does is it's conducted by the US Department of Health and Human Services, and it's a sample of, so from the registered nurses database, there's about 4.6 million registered nurses, and 100,000 of over 100,000 of them were surveyed. About half of those completely filled out responded and completed the entire survey, and those were people were included were in the sample, right? And the purpose of the survey is to provide some insight into demographics and employment characteristics of nurses. So that's what I wanted to address with my research question. And sorry. So this is my table 0, or what characteristics of a nurse in the study I wanted to focus on. And right, the outcome or dependent variable that I wanted to really address, which was burnout, was only reported in one variable where nurses experiencing extreme cases of burnout resulted in them leaving their jobs. So as you can see in the first part of the table, only about what is it, like 20,000 of the respondents left their job, and only a subset of those respondents left because of burnout. So the sample size kind of reduces dramatically from the original survey. But of those respondents that did report burning out, I wanted to compare how they responded in terms of this other question or dependent variable, which is if they would benefit from mental health training. They responded yes or no. And then some covariates that are previous research has shown that affect mental health, such as sex, age, and race, how that might affect the outcome of burnout, right? So this is again the variable map. So all the participants were nurses. They all reported their sex, their age, their race. and they all reported whether or not they would benefit from mental health training. And again, majority of them were lost because they didn't leave their job, and only a few of those that did leave their job was because of burnout. Right, and this is the table 1 showing how the different variables I wanted to analyze, right? So the important one that addresses the research question, which was, is there a relationship between requesting or benefiting from mental health training and burnout, right? And it's shown here in the p-value is that the chi-square analysis shows that there is a significant relationship between these two variables. But again, because they're two categorical variables, the magnitude and directionality of this relationship can't be discerned or is beyond the scope of this class or study, right? And then as you can see here on the top, that sex as another categorical variable didn't have a significant p-value, and along with race also wasn't a significant p-value when you had this distinct breakdown of race groups. And then the age group showed a significant relationship. So what I wanted to do later on was again, this is the same output that was in the table 1, except this is the SAS output. Wanted to show it there. This is the value, the chi-square value, and the probability, right? So, and then if I was to break down the racial groups based on white, non-Hispanics, and non-white, there is a significant relationship between race and burnout. So the probability decreases. The statistical significance of it kind of goes down to 0.2. So depending on the level of significance and the fact that we kind of shrunk down the categories, it affects the outcome or the analysis. So I thought that was kind of noteworthy. Additionally, this is just showing again that the probability for sex is not significant, how the relationship between sex and burnout is not significant. Right, so what I wanted to show then is the significance between also additionally how how many hours nurses work and how that relates to burnout. So shown at the bottom is the F value or the equity of variances, and the P value shown there is statistically significant. And what that results in is that people who report burnout have a higher mean, right, of hours worked. And you can see that demonstrated here in the box plot, where people who left the job because of burnout have a higher average hours worked compared to those who didn't, who don't experience high levels of stress or burnout, right? So again, also wanted to examine this relationship on how age might, or how many years worked as a nurse might affect the levels of burnout. Again, the t-test shows some high level significance between these two variables, or the difference in the means, right? So shown there, right? And this is the same output of the SAS, showing that people who left their job due to burnout have a higher average of years worked since they started being an RN, right? So that shows then that nurses over time experience, higher attrition or burnout because of their job, and so that's something that needs to also be investigated. And also, what I noticed in the data was that some nurses reported no desire for training or they wouldn't benefit from training, and some did. And those that do report, and again, there is a difference between these two categories shown here in the chi-square value. And what I noticed also was that the column percent was a little different between these two groups. And if you were to do like this box plot that kind of does the relative percentage, is that people who report a desire for training also experience more burnout. So I think what that illustrates is that people who experience burnout are cognizant that they have some deficits in either their training or in the organizational level, and that these people might have more insight into how we can reduce burnout or what would benefit them doing how we could help those people with their job performance, right? So some limitations of the study
1
was
minute.
that the the terms burnout and mental health training weren't well defined in the survey, so the participants they just kind of base it on their own understanding or maybe their lack of understanding of these terms. And also, the primary intent of the survey was not to collect mental health burnout, so more questions that parse through the data, a bit more of like mental health and different types of training were not evaluated in this study. I think the main insights are that there needs to be development of more evidence-based guidelines on mental well-being in the workplace, that there does exist inequities in people who experience burnout, and individuals experiencing burnout might have more insight into causes of burnout. And to that end, also nurses with more experience might have also more insight into how to better manage their stress as it relates to their work. And those are the works that I use. And that's it. So I'll take any
Don't
questions.
stop sharing. Don't stop sharing.
Yeah.
But can you make it a full slide so I can see better? Because my eyes are old. Thank you, dear. Very, very nice. Okay. Questions, clarifications.
It's a really cool subject. Not a question, just an observation.
That's okay. It's good feedback.
I'm curious to know what exactly your call to action is in this, for this. You could answer that.
Yeah, so again, I think that was kind of the main takeaway from this study is that because the data set I used doesn't have any like very specific questions like, oh, how, you know, keep like the coping mechanisms that nurses or other workers use to deal with the stress, because obviously there's stress related to all daily activities, especially in work. So the people have different levels of that. So that kind of like information isn't in this data set or study. So there's not really any call to action to be made from like what works and what doesn't. What I just wanted, I think what my analysis or data set shows is just adding to that general knowledge that there is this example of burnout and that there is inequities in different groups who experience burnout. And so that this data also supports the need for organizations to look into how they can reduce this levels of burnout, right? So yeah, that was something that I was struggling with as well. So I'm not sure if that answered it.
Just to jump in though, what Cynthia's asking is a good question, and you kind of touched on it. So I think you saw it there because you kind of described it in your findings as you kind of summarized them. What pattern was starting to emerge from the comparisons that you did in your t-test? What were you noticing?
Right. So in t-test, what's shown is that there's a difference in the mean for so people who work longer, who have worked more years as an RN, their mean years that they worked is higher for those who experience burnout versus those that don't. So
okay,
that just
but the others though. So look at them all as a whole. As a whole, though, the years of work, the requests for training, there was a couple of other ones. What do they kind of indicate, that pattern?
I think that the pattern indicates that there's like a threshold of stress, and I mean there's like obviously continuous stress related to the job, but there are ways to cope with it, I think. Right, so I think maybe people who are more experienced might have more strategies for coping with that, and also people might have strategies for just general mental health well-being, and those people probably wouldn't request mental health
Well,
training?
according to your data, the people that have been doing it longer are not coping well, because you're saying that people that have been there longer are have a greater proportion are leaving.
Right. That's sort of.
Go to your next screen. Go to your next slide.
Which one?
Look at this. And guys, you got to look at the row percent. That's the third one down. And you compare the yeses across those that do and do not report a desire. If there's no difference, they should be exactly the same. What are they here? 17% versus 29%. Okay. So less people don't want training. More people report a desire for training that end up leaving, meaning that's a flag. They're saying, hey, I need something, organization, give me something.
Right.
I'm saying, does that make sense?
Yeah, that's what I tried to show here, but I guess I didn't make that point again.
Yes,
yeah.
That's what you said it earlier. That's why I was telling you, like, you're there. But gather all of these together. So people with institutional knowledge, they've been there longer. People that are saying, give us training. They're saying, hey, these are the red flags. Listen to your people.
Right. Yeah.
Okay.
So
did you do a comparison across mental health? Because that was one I would have loved to have seen on these outcome, but I don't remember if I saw that. If you go back a little.
Mental health, sorry?
Yeah, the first question.
Oh, no. I just did if they experience burnout.
No, I'm saying like mental health on the x-axis and then experience reasons for leaving burnout.
Oh, those two are categorical only, so that's just the chi-square analysis showing there is a relationship.
Oh, okay, I see.
So
even
yeah, that's what I was saying is the limit of the study is that they don't put a number to like how much mental health training or like their capacity for coping or like their level of
I want to see row percent, because if I look at this, the row percent here on the bottom no is like 33%, and the top it's like, oh
yeah, so here's the row percent.
30% desired training, 26% don't desire training. So they're saying they don't want mental health training and they leave for burnout.
Yeah.
It's kind of the opposite, right?
Mm-hmm.
But that's the opposite of what I expected. Okay, anyway, but does that kind of make sense? So when you're thinking about the knowledge, the action, the call to action, it's putting all of this together and saying, what does this all mean? Okay, so you're practically there, but your output is phenomenal. We can talk a little bit about visualization, but the output is fantastic. Excellent t-test.
Okay.
Okay.
Yeah, thank you.
Questions, comments? Okay, it looks like Irene, you're going to be our last one. Are you ready to go, dear?
Yes, thank you so much, Jonathan. I
thank you.
it out.
Yeah, no problem.
Oh, I'm so glad. So just a quick note, while Irene is setting up, we do have a couple of your classmates that are going to be posting a little bit later. If you guys could, not obligatory, but if you could, I'll put up their videos, and if you could, if you have time to give them feedback sometime this week, I know they would be grateful, but that is certainly optional. So they just had a little bump in the road, so they're just gonna load them a little later, okay? Everybody else for next week, same applies. Okay, go ahead. You ready to go, dear? Oh, hang on, let me start the timer.
Yes, thank you so much. Okay, let me know if you hear it or if you don't.
Yes, let's
17 on our mental health needs and foster youth being met. So I will be going through data, information, knowledge, and decisions and recommendations. So for my table of contents, I will begin with the introduction, going through the significance, literature, methods, which will be my data source and study design, the results, the discussion, decisions, and finally the conclusion. So to begin with my introduction, why are the mental health needs in foster youth being met? Why is that research question important? So the significance is 400,000 children annually will be placed in foster care. 49% of children in 2017 who entered the system were age 5 or younger. So not only do these children, not only are they taken out of their homes, but they also experience, depression, low self-esteem, and they also struggle with their health and well-being. In San Diego County alone, 93% of children from 2017 to 2018 entered the foster care system due to neglect, physical abuse, or sexual abuse. And for the literature, I chose 3 different journal articles, which is an exploration of the health and social well-being needs of looked after young people, and a preliminary analysis of the receipt of mental health services consistent with national standards among children in the child welfare system, and lastly, mental and physical health of children in foster care. So they used a multi-method approach, a longitudinal study, and also a cross-sectional study. So it was concluded that 40 to 60% of children in the child welfare system have a psychiatric diagnosis, and children in foster care have between 10 and 20 times the rate of utilization of mental health services when compared with children maintained within their homes. And it was also found that children in foster care are in poor mental and physical health compared to children in the general population, children that are in different family types, and also children in economically disadvantaged families. So for my methods, the data source that I utilized was the National Longitudinal Study of Adolescents to Adult Health, which is AdHealth. And Wave 3 data was a follow-up interview with Wave 1 respondents when they transitioned into adulthood. And the in-home third wave interviews allowed researchers to document how the adolescent behaviors and experiences relate to health outcomes and behaviors during their transition into adulthood. So the Wave 3 data collection was conducted nationwide. It included Hawaii and Alaska, and it was between August 2001 and April 2002. And the study design, so for AdHealth, it's a longitudinal study. It incorporated several new features into this specific wave, such as binge sampling, college context, biological specimens, and also couple sample. And so the average response rate was 76%. And in total, AdHealth completed about 15,000 interviews for respondents on Wave 3. And for the analysis, so I incorporated Pachansky 5As when considering my research question and answering it, and also the social determinants of health, so considering lifestyle, medical care, their environment, and also hereditary, and also health equity. Additionally, this is an observational study, so it's population-based, which means it's descriptive, and it was utilizing a health survey. For the results, I think it's really important to focus in on this question. Has there been any time in the past 12 months where you thought you should get medical care, but you did not? So about 22% of respondents said yes, that they did not get medical care when they thought they should. And it's important to note that this survey was completed in 2001 from 2002. So this is before ACA. So it would be super interesting to compare these results to a survey post-ACA to see if these children, if their parents were newly eligible for Medi-Cal, and if their access to care increased. So if their parents don't have to worry about paying for health insurance, maybe they're able to afford gas to a doctor's office or are able to take off of work to get their children the medical services that they require. And now for my cross comparison. So I would also like to note that only 2 individuals or participants are within the ages of 26 to 28. And why this is important is because foster youth are eligible for Medicaid until the age of 26. in all 50 states. So when it's saying here, if there's been a time in the past 12 months when you thought you should get medical care but you did not, this number is really high, 17, if only 2 are between the ages of 26 to 28. So this means that they may not know that they're eligible for Medi-Cal within California, or if they live in a different state, Medicaid. And it means that their access to care needs improvement. So specifically looking at if they got health insurance when it was offered, and if they lived in a foster home, 10 said that they did not get health insurance when it was offered. This number is still too high, although there are only 75 participants, like 10, I think that's still way too high. So there needs to be programs to educate youth on their health insurance options. If their parents aren't able to do that research themselves, then there should be programs to ensure that those youth are getting the care that they deserve. And also you want to consider perceived access. So if they have insurance or if they don't, and also realize access. So maybe they do have those services, yet they are not utilizing the services, or their access to services needs improvement. And now for the discussion, so findings. So foster youth, they might be unaware of health insurance offered through Medicaid and other health service programs that are covered specifically for mental health. And if 22% of participants said that they did not get care when they should have in the past year, access to care still remains a problem for many youth. So it would be really interesting to see post-ACA if there is improvement in foster youth and also, education. So knowing that they have that care and what they are eligible, what services are eligible. So strengths, the survey questions ask questions about mental health and foster care. It also incorporated some of the Pachansky access model considerations. And the limitations of this survey is that the sample of foster youth who completed the survey was very small, and they didn't ask questions about current foster homes, so health equity. So are foster youth parents able to afford gas to and from appointments? Also, social determinants of health. What is the child's current lifestyle and environment? So can they afford it? What's the availability like, accessibility, accommodation, and acceptability? For decisions, so the problem, many barriers exist for foster youth in the system to receiving accessible, safe healthcare services, such as mental health services. The solution for this is perhaps to create a rideshare program for those that already are covered under Medicaid. So maybe that they don't have the resources to get to their appointments. So CASA volunteers, CASA is a court-appointed special advocate. Perhaps they can transport their case children and other children to appointments and make that, part of their duties. So making sure teenagers in foster care understand their health plan provided through Medicaid, I believe that will be really important. In conclusion, foster youth experience unique challenges. However, through development and implementation of health service promotion programs, access to care for this group can become more equitable. So further data is needed because the sample size is small. However, the results still remain eye-opening. And lessons learned. So first, making sure your data set is available to the public. I know I ran into that one. And also for number 2, to revisit possibilities.
So I don't have time to go through all my lessons learned, but maybe I can post my PowerPoint. But the rest of my presentation is just my references. And thank you.
Excellent.
There's.
Okay.
All right. Well done. All right. Clarifications, questions, comments?
You see the tables again real quick?
Oh, Luke, you go.
Yeah, I forgot to tell you, don't stop sharing.
Okay, let me put it back. I'll put my PowerPoint up so that it's easier. All right, here we go.
Okay, and what table did you want?
This is, yes.
Okay.
I just wanted to look at them again.
Okay. My table 0, and then when you want me to go to my table 1, just let me know and I can switch over.
Irene, did you consider?
So this is the entire sample.
Irene, did you consider?
Sorry, say that again.
Sorry. Did you consider looking at education and that impact on whether or not they knew their perceived access to medical care?
That's actually a great question, because my original research question was looking at if higher education, or it was like looking at the correlation between education and mental health services and performance in school. But with like the available data set, I was only able to really narrow in on mental health services. And I didn't see anything in the survey to include specifically around education, but that was something that I was really interested in.
I bet it has a years of school variable in there. Now that you're pro in this data set.
Maybe like what grade you're in also for age.
Although 18 to 21, so if they even graduated from high school, for example.
Right.
Good one. Anybody else?
And one.
I really liked your research question, Irene.
Thanks. Some background too. One of my brothers is adopted, and he was adopted through foster care. Like several foster siblings growing up, and it was cool.
Wow.
I was able to meet his 3 other siblings. He has 6 in total, so that was a really neat experience for me.
I love it when our research is driven by our passions, our interests, and our experiences. That's the whole point.
Mm-hmm.
Wonderful. I think this is excellent. I have a few questions. Well, sorry, go ahead. Anybody else? So I also share the question about education, and then also insurance status, because you mentioned Medicaid eligibility.
Right.
And so I'm curious if foster youth are immediately given Medicaid, or if they're eligible, or or foster families are given the option versus whatever insurance plan they have, so on and so forth. So I'd be curious if that has any influence.
Right. I also was when I was talking about pre-ACA, post-ACA, I was specifically talking about expansion. And in my mind, so foster families, if they're newly eligible for Medicaid, like their foster parents, maybe that's less money that they're spending for insurance. So they're able to use that money for their foster child to take them to appointments. And not to say that all foster families, definitely not all of them do it for like the wrong reasons, but there are families that do it for the money. So I think that could be also a problematic or area to focus in on.
So maybe the household income might be a good covariate to look at as well.
Definitely household income.
To insurance. That's great.
Mm-hmm.
Great. So I recognize I've gone way over for everyone, but I think these presentations have been exceptional. I'm very proud of all of you that have presented. I look forward to the presentations coming in next week as well. I want you to realize that this is a huge accomplishment. And every single presentation that I've seen, you should really think about doing a student research symposium poster. Those of you that have never done an academic poster, this looks great on your resume. So you have a writing sample out of the gate. If you don't want to do a poster, you can do a talk. But I strongly encourage you that you all have material that could be reworked into that. If you don't know what I'm talking about, Google SDSU Student Research Symposium and let me know if you're interested. but I'm very pleased. So going forward, I would like to propose starting at 1 next week, if it's not too early, just to give us plenty of time, because I know you, just so you guys have a little break between your next class. But I don't know how everybody feels about that. So if we can take a quick vote, show of hands on no or yes. Or if you guys want to vote privately with your Facebook group and then let me know, and somebody can be a representative, let me know. Or just vote in the comments. Then 1 o'clock is okay. Then that way we have plenty of time for everybody, because we do have 8 total next week, and that's a lot still. We only did 6 today, and look how far we went. But everyone's discussion, comments, presentations were really good. So Friday is when your presentation's final, like the PowerPoint is due, with some comment from, incorporating any comments that I provide to you. And that's your final deliverable, which you upload into the final project. So there's a file upload there, okay? Remember, there's a final project assignment. If you haven't looked at it, there's a final project assignment tab. And you upload your PowerPoint there, okay? Any other questions, comments, thoughts? 1, 2, 3, 4, 5, 6. I only have 6 votes for yes in the comments. Anybody else, if you haven't voted, could you please vote in the comments?
That's fine with me. Just to clarify, so the people that presented this week, our final presentation is due this Friday?
Yes.
Okay, got it.
Can you remind us where to upload the feedback form?
So now, okay, so let's do this real quick. I'm sorry if you have, and I'll record this so you can look at the recording if you have to run, but here, I'll show you real quick. Let me, oops, that's not right. So let's say I finished my thingy. And now I want to upload my thingy, I'm sorry, I'm not using any proper words. So let's say I finished my, my form, and I want to go and upload my day 1 feedback. I go over here and I'm like, okay, day 1 feedback. Okay, where is it? Let me see it. Oh, drat. There it is. So I go here, click. See this? And I take the survey. Question 1, I upload there. See where it says day 1? That's where you upload that Word doc.
Thank you.
And then you'll come back, and once I submit that, it'll pop up day 2. But there's no, ignore the timer. I know it's going to annoy you. So it's going to be like a week long. Don't worry about it.
Will you email us the feedback?
I will be emailing presenters their feedback.
Okay.
I will be emailing the 7 people today or 6 people today their feedback. It will be my feedback and then anything that students present. So you should get it by tomorrow morning. So everybody, please load this by tonight so that I can look it over in the morning and add anything that you convey for our presenters, and then I'll summarize it all for them too. Make sense? But I do, and like I said, it's not punitive, but we do this for our profession, right? So part of being a healthcare professional is to give each other feedback. So just take the time. It doesn't have to be a ton of feedback. So please don't feel that pressure. It's more about like what's just something that stood out, okay? But the other thing about the conciseness of these presentations is this is what you would do when you're presenting a quality improvement project or something that's happening in your hospital to a board. Something short, sweet, and to the point like this. So you guys, this is a template you're going to use probably for a very long time to come. So good job, guys. Anything else? So next week, 1 o'clock, I'll send an email out about it too, though, okay? All right. Thank you all very much. Please don't forget to upload your form tonight. And have a great night. Good job, you guys. Good job, group 1.
Thanks, everyone.
And I'll stay here
Thank
if
you.
anybody has any questions, but I'm done. I'm stopped recording and we're done.
Bye.